Hello. Good evening, students. Good evening. This is Dr. Punit Bhojani here, your NEET PG educator for the OBGYN subject. I think, can I get a thumbs up if all those who are there from where we are streaming, there would be a slight lag of around 10-15 seconds. So, can we verify that whether we are live or not? We are streaming, there would be a slight lag of around 10-15 seconds. So, can we? And can I get somebody in the chat box also? Uh, yes, hello. Yes, so are we live? I think so. Yes, thank you. We are live, and can also those who are there in the chat box, can you put in something so that we know that the chat box is also perfectly functioning, and we can begin our session. So today we are on the session for the upcoming uh, FMGE examination. Yesterday we had taken a session. Yesterday we had taken a session for Sure Shot MCQs. It's perfect. Yeah, thank you, Mohammad Jafar and Sonu Chahal. Yes. Okay. So yesterday we had a session of FMG for the INI CET Sure Shot MCQs, where we discussed some of the important MCQs, and today we plan to discuss some of the short MCQs for the upcoming FMGE examination. Let me just begin by wishing you season's greeting, wishing all of you a very happy Diwali and a prosperous new year in advance. And let us begin. Just a couple of things. So all of you are aware of the Unacademy app and the NEET PG offerings, but just a couple of things. Okay, so this is a nice feature, Compete, where you can just download the Unacademy app. It's now live on the Android app, and the battle and know where you stand. So it's a nice feature which has started, where you can one-to-one compete with your colleagues and friends and solve MCQs and see who is doing better and who is faster. Similarly, this offer valid from 19th to 22nd of October. Okay, and please use the code mentor, mentor. Mentor would be the code to get yours. Here we are giving 1 month extension free on a package of 4 months. Okay, at just this very extremely reasonable price. Okay, so mentor would be the code to get the 10% off. Okay, and yes, welcome all of you. Welcome, yeah, Hayatul. Yeah, okay. And yes, and these are the packages offer 4 months, 6 months, 12 months, 18 months as per your convenience. So please use that. And all of you are aware of the features, live lectures, top educators, anytime, anywhere, question bank, any device of your choice, live classes as well as recorded lectures. Okay, and iconic subscription also available, which is a combination of Unacademy and Prep Ladder. Special class features, all of you know, polls, raise the hand, you never miss a lecture, anytime, anywhere. Raise hand also extremely good feature, where you can directly talk to me during the class. So basically, mentor would be the code to get the discount packages of your choice. So join as soon as possible so that you get the maximum benefit, and download the Unacademy app. Okay, so basically we are going to discuss some of the MCQs, and I want all of you to participate. Right, wrong does not matter. So let's begin our day with the first thing. Anybody identify this image? Okay, that is the questions also asked in past years FMG. So this is a short MCQ for the upcoming FMG as well NEET PG. Identify this image, and this is what is a HSG, hysterosalpingography. So can anybody tell me what is the uh, what is this image? Can anybody tell me what is this image? Yes. Anybody, what do you think is this image? Okay, yes, Ramya, very good. Okay, so this is what, if you see, now let us discuss one by one. This is not a normal HSG. Why? Because a normal HSG would have a triangle cavity. Yes or no? Normal uterine cavity is triangle, and then you see both the fallopian tubes. All of you please pay attention. And then what do we get? How to know the tube is patent or not? By the spill of the dye. So this is a normal looking HSG for all of you. This image is very important. So that is not the normal HSG. Asherman syndrome, we had also discussed in our yesterday lecture. Asherman syndrome is your intrauterine adhesions. So when there are intrauterine adhesions, can anybody tell me what would Asherman syndrome look like? Sir, Asherman syndrome will have multiple filling defects. Okay, Asherman syndrome will have multiple filling defects because excuse me, because of all this adhesions, the dye will not enter that part. So when you get multiple filling defects, that is Asherman syndrome. So that's also not there. I'll explain to you what is bicornuate. And this is a unicornuate. Why? Clearly it's like a banana shaped uterus, as we call it. Okay, one half. Okay, one, you can clearly see over here, this is the shape of the uterus, and then only one side fallopian tube is seen. So when normal cavity is triangle, but when only one side of the uterus is seen like this, any of these, that is a unicornuate appearance or a unicornuate uterus. Very, very important MCQ. Now, can anybody tell me, it's not a bilateral cornual block. Bilateral cornual block means only the uterus is seen, and the dye, both the tubes are blocked at the cornual end, and the dye does not enter the tube at all. Okay, so all the important features, so with this one MCQ you have covered 4 or 5 MCQs. So when you see only the uterus, is seen and both tubes not seen, when both the tubes are not seen, that time we call it as bilateral cornual block. Okay, that's again not the case because one tube is seen over here. And bicornuate is of course when we see 2 horns, but they'll be wide apart. Okay, so when you see one horn like this and another horn like this, that is a very wide apart, that would how be a bicornuate uterus be. Okay, so this is an unicornuate appearance of the unicornuate uterus on a HSG, hysterosalpingography. It's primarily a test for tubal patency. So we have discussed all of it, and this is the answer. Yes, is it clear to all of you? Yes. Now let us go on to one more image based MCQ. It's again a very popular MCQ. It has come in the past also and likely to be repeated now also. That if a patient, okay, this is again a ultrasonography. What is it showing you? We have a history of a patient, that in the history we have got a patient of infertility and ovulation induction agents were used. Specifically, they would like to say, because this condition very unlikely with clomiphene citrate as well as letrozole. So HMG, human menopausal gonadotropin, or a recombinant FSH is used for ovulation induction. So what does it look like? Anybody, what do you think is it? Is it PCOS? Is it OHSS? Is it a endometrioma? Or is it a dermoid cyst? Okay, endometrioma is your chocolate cyst. Okay, it is your chocolate cyst of the ovary which you get in cases of endometriosis. Okay, why is it not PCOS? Very good, all of you. Atul, Ramya, Muntaya official 1996B. Yes, all of you. This is ovarian hyperstimulation syndrome. Specifically, when there is a history that sir HMG or FSH was used for ovulation induction. So this is a very, very important thing. The point to be kept in mind is that in PCOS they are, what is the typical pattern? So there are multiple small follicles and all will be arranged in the periphery. What is this pattern called as? Anybody? What is the pattern called as? Yes, the necklace of pearl pattern, or a neck or a pearl of string pattern, or string of pearls appear. So there is a necklace pattern where you get small follicles. Okay, small follicles. Here the important part is, if you see all these are big follicles. If you look at the 1, 2, 3, so this is like a multi-stimulated ovary. Multiple follicles are growing together. Okay. Yes, PCOS will also have a thick stroma. Okay, very good. So here what we are getting is, basically we are getting this big bulky ovary, and inside that multiple follicles have started to grow. Multiple follicles have started to grow, and along with it, actually always remember, this is an incomplete. They should also show you some amount of ascites and free fluid. Okay, because this, by the way, this PG level, that this picture could also be of a stimulated ovary. By stimulated ovary, I mean if ovulation induction agents are used, then a stimulated ovary would also look like this. To call it OHSS, ovarian hyperstimulation syndrome, some amount of ascites and free fluid should also be there. So when along with this kind of a picture, if you get free fluid if you get in the pouch of Douglas, and that means ascites is there, then that is good enough to tell the patient that it is OHSS. Couple of very important MCQs we should know regarding OHSS is that VEGF, vascular endothelial growth factor, is one of the most important agent implicated in the development of VEGF, and the final culprit, I would say, is the HCG injection. Remember, no HCG, no OHSS. When finally injection HCG is given as a trigger, okay, we call it as a trigger to make the patient ovulate. Initially always HMG or FSH is given to make the follicles grow, but then the final is HCG injection is given, and that causes OHSS. Remember, this is very rare, almost never seen with clomiphene citrate and letrozole. Okay, letrozole almost never, and clomiphene extremely rarely gives rise to OHSS. This is mainly with the use of gonadotropins, because they give rise to multiple follicles. PCOS is a risk factor, okay, for development. But PCOS patients who have undergone treatment with ovulation induction agents, specifically HMG and then HCG is used, are at a high risk for development of OHSS, ovarian hyperstimulation syndrome. So this is a kind of a relatively newer topic based on which MCQs have started coming in your entrance examination. Okay, so let us go on to the next question. And that is, anybody can you yes, so again an image. What is, identify what is this image? Okay, is it a ring pessary? Is it a tubal ring? Is it an implant? Is it a IUCD? Okay, yes, anybody in the chat box, anybody? Oh, so we're on another channel. Yes, okay. No, Gauchival, this is not a ring pessary. This is not a ring pessary. This ring pessary is used for prolapse. Ring pessary is used for prolapse, and this is a, yeah, yeah, so please understand this. Yes, so basically what is this? You are seeing a packet. Okay, you are seeing a packet, Dr. Mundial, and you are seeing two small white color. Can you focus over here? So these are your silastic bands. These are your silastic bands, which are called as tubal rings. And anybody, what do we use those tubal? Yes, they are so small. Yes, correct. Okay. So they are so small, they are just white color, so small, and they are used for tubal ligation surgery. They are used for laparoscopic. Basically, whenever we do a laparoscopic surgery, we are using it for laparoscopic sterilization procedure. Okay, so laparoscopic sterilization procedure is this. Okay, so laparoscopic sterilization procedure is the procedure, is the name of the surgery which we do this. It's a family planning surgery. An implant would be something like your matchstick. Okay, implants are contraceptive implants which you put in the forend of the hand. IUCD, all of you know, will be like a copper T. So it will be like a T-shaped device where there will be a copper wire. Okay, This is understood to all of you? Yes. So tubal, these are the tubal rings which we use for laparoscopic sterilization procedure. Yes. Now anybody, this was again one of the very important MCQs which could be asked to you in the exam. We have got a 25-year-old patient. She, after giving birth, continues bleeding from the uterus. So basically she is having postpartum hemorrhage. Postpartum hemorrhage. Okay, the patient was taken up in the OT and planned for a devascularization. Now what is this procedure? Stepwise, this is called a stepwise devascularization. It is one of the treatments for PPH. Okay, in PPH, when we use the massage, we use the drugs, we always go for the medical management first, and when the medical management will fail, so what are the drugs what we use? So we can use oxytocin, we can use methergin or methyl ergometrin. All these are very important drugs. PGE1, PGF2 alpha, all these 4 drugs you should please remember, which are used in the medical management. Oxytocin, in the actual classes we discuss how to give, what dose, all that. Okay, PGE1, PGF2 alpha, all that are used. When the medical management fails, then I proceed for the surgical management. Yes, and in the surgical management, very good, Atul Saini and Smith Patel, very good. That what is the correct order that is asked to you? So do I go for uterine, pudendal, vaginal, uterine internal iliac obturator, uterine ovarian internal iliac, anterodivision, external? So no, you do not ligate the external iliac artery. Why? Because external iliac artery continues as femoral vessel. So no, that is not ligated. So what is done is that initially the uterine artery or the uterine vessels, those are ligated, okay, to control the bleeding. How does the ligation work? That sir, when I ligate the blood vessel, all of you pay attention, this is the blood vessel, when I ligate it over here, the blood flow slows down. The blood flow across the ligation will slow down. There is stasis and blood starts to clot. Okay, blood starts to clot and therefore the bleeding stops. So we ligate the uterine vessels, then we ligate the utero-ovarian anastomosis, and then we proceed to ligate the internal iliac artery. But the important point is that internal iliac artery, all of you should know from your anatomy, it has got anterior division as well as posterior division. Okay, the anterior division is to be ligated because uterine artery, anybody, uterine artery is a branch of anterior division of internal iliac. Okay, is this understood to all of you? So whenever I have to ligate the internal iliac artery, we should always ligate the anterior division and not the posterior. There's no point ligating the posterior division. Is understood to all of you? So this is again a very important point, and therefore the answer is very good, sir. Uterine artery and then proceed for internal iliac, in the anterior division and not the posterior division. Okay, so that is the order. Okay, this pudendal and all that are branches of this only anterior division. So once you ligate it, that is good enough. Okay, so this is again a very important MCQ for the upcoming examination. Remember the medical management also quickly I have told you about the PPH. Overall PPH is a very important topic. Okay, and the surgical management also for the PPH, the basic things we have told you. This is called as a stepwise devascularization, and then ultimately there are some compression sutures which we take on the uterus, and as a last resort to save the patient's life, we might have to do the hysterectomy. Okay, that is called as obstetric hysterectomy to save the patient's life. Okay, so yes, let me see, there's one more question. Okay, so this is done, yes. Now can anybody? Yes. So this is again a very likely question for the upcoming exam. We have got, what have we got? Sir, we have got a primigravida, 39 weeks of gestation. She is 10 centimeter dilated. So she is fully dilated. Okay, she is fully dilated almost since 1 hour, and on PV examination supraorbital ridges are felt as well as anterior fontanelle is palpable. Can anybody give me the diagnosis? A patient who is in labor, and if on PV examination supraorbital ridges of the baby as well as anterior fontanelle, what do you think? And the electronic field mounting shows a reactive fetal freezing. Reactive matlab normal. Okay, so baby heart rate is okay. Which of the following is the most appropriate management of this patient? Anybody? Can you tell me? It's a difficult MCQ, but if you have paid attention in the previous lectures or if you know the concept, you can get it correct. Any idea what is your diagnosis? Yes, Atul, Ramya, Guj, Evil, okay. ऑक्सीपिटोमेंटो नहीं होगा बेटा, ऑक्सीपिटोमेंटो जैसा नहीं होता, बिकॉज ऑक्सीपुट इज हियर, मेंटम इज हियर. ओके, सो इट कांट बी बोथ. सो व्हाट इज दिस? ओके, perform no, Ramya, you are wrong. I do not. First of all, internal podalic version is a very dangerous procedure. It should not be done. But by the way, it was a old procedure. Internal, I like this internal podalic version. What you are telling me, internal podalic version, what you're telling me is a outdated procedure. There's a very high risk of rupture uterus in this. But by the way, also here it is done for transverse lie, if at all. What is internal podalic? So this is not a transverse lie. Transverse lie may they will say that the lower pole is empty. Is it very clear to all of you? That's a very important clue. Transverse lie matlab the baby is transverse. And on PV examination we feel the shoulder. So remember students, is a very important again clinical finding that when they say lower pole empty and on PV shoulder felt, that is a transverse lie. And transverse lie also we should always do LSCS only. Internal podalic version means you put your hand inside the uterus and rotate the baby. That is causing all this rupture uterus, lateral wall rupture uterus. Okay, so this is not to be done, and anyway it is not possible to be doing over here because this is not a transverse lie. Again, you do not perform a forceps and convert to mento posterior. Mento posterior is your face, and in mento posterior face a vaginal delivery is not possible. This, anybody, this is your brow presentation. That is the very important. What is the meaning of brow presentation? This much. See, when ear to ear, when the baby is from ear to ear, that is called face. But when the baby is midway, see here, can you see? I am doing that. If I am the baby, all of you assume if I am the baby, then when you do a PV, you will feel the supraorbital ridges and you also palpate the anterior fontanelle. So this is a brow presentation, and the important part is how do I deliver brow? LSCS. Why? Because sir, brow presentation, all of you pay attention, all of you note down that sir, in brow there is no mechanism of labor. Why is there no mechanism of labor? Matlab labor is not possible only. Are all of you understanding? Labor, whatever you try, uterus will keep on contracting, prolonged labor, obstructed labor, rupture uterus, and the mother will die but the baby will not come out. Why? Because you are also supposed to remember this number, that in brow the engaging diameter is mentovertical, which is 14 centimeters. Okay, please keep this point in mind. In brow, all of you remember, these are the only 4 points to be kept about in brow or remembered in brow for your exam. That sir, in brow, how do I know it is brow? Sir, when supraorbital ridges of the baby are felt plus the anterior fontanelle palpable, that is brow. It is the least common. By the way, brow is the least common variety. Okay, it's the least common presentation, least common malpresentation. Okay, so brow is rare, and there is no mechanism of labor, and therefore for brow, what am I supposed to do? LSCS. If it's a persistent brow, like in this case, sir, it's a brow, patient is pushing. Is this understood to all of you? Can all of you tell me yes in the chat box if you have understood this? So sir, this is brow, and therefore first is the answer. Perform a immediate LSCS, because already the mother is pushing for 1 hour. This baby will not deliver, and you are not wait and watch and encourage her to push. No, this I do when I know that there is a chance of a delivery. Brow is anyway not going to deliver. I cannot. So mento vertical याद रखेंगे, 14 centimeter याद रखेंगे, and LSCS has to be done. These are all the points which you will keep in mind for the for your brow presentation. Is it clear to all of you? Yes. Moving on, let us go to the next question, and all of you please try to participate in the question. Yes, Mr. and Mrs. XYZ married since 1 month. So they are newly married. Okay, newly married, have come to you for contraceptive. Contraception again is a very short topic. Patients wants to delay pregnancy for 1 year at least. Both partners are healthy. So that's a clue given to you that they are healthy. Both husband and wife. What is your best advice? Anybody? What will you? So this is indirect. It's the longest question for asking you indirectly. Contraception of a choice. Contraception of choice in a newly married couple, or if they tell you the patient is planning to get married next month. Okay, newly married couple. Okay, very good. Rekha, Meena, Muntayal official. Uh, Yes. So here please understand this. Condoms, they slightly decrease the sexual pleasure, but other than that they have got a very high failure rate. You would want to. Condoms are good for preventing sexually transmitted diseases from partner, but they have got a very high failure rate. Can anybody tell me what would be the failure rate of a condom? Please remember 4 to 14%. 4 to 14% is a failure rate. 4 to 14% is, so it's a very high failure rate, and you wouldn't want to advise it to a married couple. Similarly, spermicidal agents again have got a very high failure rate, and they are not to be advised in a newly married couple, and overall also we should try to avoid them because they're not a reliable method. Vasectomy is of course a permanent method. Okay, you can't suggest it. Okay, it's a permanent method for male sterilization. So when nobody is marked. Okay, it's a permanent method where there is, what do you call, they are this married only since 1 month. This couple is married only since 1 month, so you can't offer them permanent method. Okay, and OC pills, very good. Why OC pills is very good? Because our OC pills have got lots of benefit, and OC pills will give her regular cycles, and again very, if they take properly, very low failure rate. And OC pills can be safely taken for 2, 3, 4, 5 years. They want to delay it for a year. Okay, so they have got a good failure. Both this B and C. Now why I will choose C over B? Both have got a very low failure rate, but IUCD is better after one pregnancy. All of you know IUCD comes under the category of long acting. IUCD, all of you know, is like say 3 years, 5 years, 10 years, like that. Okay, so this is long acting and reversible. So can anybody tell me which are very good patients for IUCD? Which are a very good couple for, which is the best patient, like one good example where I can go for IUCD, where I should go, because he is just married. So she's a nulliparous. In nulliparous patients we avoid. This is a nulliparous. Nulliparous means she has got no babies till now. She's married only since 1 month. So she's a nulliparous patient, and in nulliparous patient we preferably avoid IUCD. It's not that you can't give, you can give, but it's better to be avoided. So IUCD is out. So this is how you rule out, and you know the answer is OC pills. Okay, so anybody, IUCD, all of you pay attention, is very good as a spacer device. Anybody, what's the meaning of a spacer device is? What is the meaning of spacer? I mean, it's possible, patient, not long distance. Okay, okay, that sir, if one baby is already there, patient has delivered a baby, and now they want to wait for 2-3 years for another baby. So in between, because they are long acting and they are reversible. Is this understood to all of you? So here your IUCD is very good, because when you want birth control for 2, 3, 5 years to gap in between one baby and another baby. Okay, is it clear? Yes, OC pills better. Dikshit Bala, you are correct that every day they will have to take, but that's the best option because in the nulliparous patients who had not had any pregnancy till now, it's better to avoid a IUCD. Insertion should be avoided. And by the way, healthy is the clue given to you at the lady. Why? Because sir, OC pills can't be, just by the way, OC pills cannot be given to a lady who is having severe smoking, severe hypertension, severe diabetes, complicated migraine. All these are contraindications for OC pills. I hope you should know that. That sir, OC pills are contra. What are the contraindications for OC pills? Sir, OC pills. Anybody? OC pills are contraindicated in which patients? So sir, those who have got thrombophilia, deep vein thrombosis, ischemic heart disease, complicated migraine. What is the meaning of complicated migraine? Migraine with aura. Those who are having severe smoking, 2036, so thrombophilia, DVT, ischemic heart disease, complicated migraine, severe hypertension. So see, with one MCQ we discuss so many MCQs. Clap if you feel happy. Severe diabetes. Diabetes matlab ke? Yes, and very good DS. Active liver disease, because OC pills are metabolized in the liver. So liver disease as well as breast cancer. If you already have a breast cancer, as well as if you are breastfeeding. Okay, because estrogen decreases the quality and quantity. So lactating mother you cannot. Breast cancer is, yes beta, definitely. Breast cancer, Prashant, is a contraindication. Okay, breast cancer is a contraindication for OC pills. Okay, ovarian cancer no, but okay, breast cancer. Okay, so breast cancer patients, again breast cancer survivor with a strong family history. So all this is ruled out. So she does not have liver disease, she does not have hypertension, diabetes, she is not smoking, because that is told to you that she is healthy. So contraception of a choice in a newly married healthy couple is OC pill. This is what I do day in day out regularly. We prefer to give a this. Okay, so this is out. Okay, so this is how you keep in mind. Condoms out, high failure rate, 4 to 14%. Spermicidal agents, again very high failure rate. Vasectomy is a permanent method. You only suggest when the family is complete. Between IUCD and OC pills is preferred, because IUCD, if the same patient, they tell you that she is para 1 living 1. Okay, the question comes that sir, patient has already one baby and now she wants to delay pregnancy for 2-3 years, then what would be the choice over here, all of you? So then I would like to go for IUCD. Is this understood? Because IUCD is a spacer device to space in between two pregnancies. It is always very good to go in for IUCD. Okay, so that's our time. I hope all of you had a great time. And by the way, okay, tomorrow morning, okay, tomorrow morning at 9 a.m. on the Unacademy platform. So please download the Unacademy app. It's a free class. It's a special class for all of you. Okay, it's a free class, special class. Tomorrow is 22nd. Okay, tomorrow is 22nd of October, morning 9 a.m. Saturday morning. I invite all of you, please. IUCD beta is intrauterine contraceptive defined. Okay, it I will discuss. Okay, so G3P3 okay, so Saturday tomorrow morning special class free for all. Beta doctor died. IUCD means intrauterine contraceptive device, okay, or a copper T. Okay, so 9 a.m. tomorrow morning, all of you welcome on the Unacademy platform. You can use the code mentor to get that subscription, and even for enrolling or for seeing the class, it's a free class, free for all. Just use the code mentor to log in. Okay, and download the Unacademy app. Use the promo code mentor to unlock the free content. And all of you, I would like to see you tomorrow morning, where again we're going to discuss some of the important MCQs for the upcoming NEET PG and FMGE examination. Okay, and all of you can enroll and take the benefit of this offer if you hadn't taken it, and the promo code is mentor, MENTOR. Okay, so bye bye, best of luck, thank you very much for coming in today. That's our time, and wishing you very happy Diwali and a prosperous new year in advance, and see you tomorrow morning at 9 o'clock for 9 to 10. It's a 1 hour free class, free for all. So all of you can come in on the Unacademy app.